Thanks, Alex. So over the next 25 minutes, again, I have no disclosures. If you take a peek at your syllabus, you'll see the learning objectives. But I want to get moving because we do have a lot of information to cover. And hopefully by the end of this talk, you'll get some idea of why Jehovah's Witnesses believe the things that they do, how this impacts both their risks for outcomes in terms of hemorrhage, and what we can really do to care for these patients to the best of our ability. I want to start off with a case that demonstrates why I think this is such an important topic. This happened a number of years ago at the University of Colorado. The patient was a 37-year-old G5P4 who had a history of 1 previous vaginal and 3 really uneventful C-sections. Unfortunately, she was admitted at about 28 weeks with a complete placenta previa and a placenta percreta that was noted to be invasive into the bladder, the abdominal wall, and even the pelvic vasculature. At 30 weeks, she came into the hospital to be optimized with IV iron and erythropoietin. And at this point, the obstetricians and gynecologic oncologists were quoting her about a 75% risk of death if she refused transfusion during her upcoming cesarean delivery and hysterectomy. Despite this, the patient remained adamant that she did not want any blood transfusion. Her husband was not a Jehovah's Witness, and he was equally resolute in his desire for his wife to receive a blood transfusion. As a result, the hospital's legal and ethics teams had to be involved, and a special power of attorney was developed to give the husband decision-making capacity for everything except blood transfusion. The patient went to the operating room at 34 weeks. She underwent isovolumic hemodilution. A continuous circuit cell saver was hooked up. Unfortunately, she suffered a very significant hemorrhage requiring retransfusion of all of that blood, a dose of factor VII, and at one point manual compression of the aorta. Despite this, and a blood loss of about 6 liters, her hemoglobin remained around 4 when she was taken to the ICU, and she was actually off all pressors and had minimal drain output at that time. So I'm going to step away for a moment to give a little bit of background on obstetric hemorrhage. This remains the #1 cause of maternal mortality worldwide, and overall accounts for about 30% of maternal deaths. Depending on what study you look at, the incidence can range from 4 to 6% based on a nationwide inpatient sample of the United States in 2010 to about 1.2% of births based on this 2014 very large multi-institutional World Health Organization survey study. Regardless of that, atony remains the #1 risk factor for obstetric hemorrhage. Apart from atony, there are many significant risk factors. These fall under socioeconomic, obstetric, medical, or even systemic categories. But something that's important to note is that along with things like preeclampsia or operative delivery, abnormal placentation has a very significant place on this list. And when I say abnormal placentation, I'm really talking about placenta accreta, increta, or percreta. And we'll get into a pretty detailed discussion of that in just a moment. But I just want to highlight that these 3 conditions combined become a very significant cause for emergency hysterectomy during a postpartum hemorrhage situation. And the incidence is really increasing, again, as we see an increasing rate of primary cesarean and then subsequent repeat cesarean deliveries. When it comes to how invasive the placenta is and what the risk of bleeding is, there's long been a belief that it may be related to the degree of invasiveness. Dr. Butwick and his colleagues looked at this in 2014 and actually saw that between placenta increta and percreta, there's really no significant difference in the rate of massive transfusion or the utilization of blood products. Unfortunately, we also know that hemorrhage leads not only to just morbidity and mortality, but may also have medical legal implications. In the closed claims analysis, it looked specifically at all hemorrhage cases in the realm of anesthesiology. Of all obstetric claims, about 10% were related specifically to hemorrhage. And the authors revealed that the hemorrhage cases specifically had overall greater severity of injury, a higher rate of anesthetic care being claimed to be less than adequate, and commonly cited communication breakdowns between anesthesia and the obstetricians. So we're going to go back to the ICU where we left our patient with a hemoglobin of around 4. Fortunately, that's not where the story ends. About 45 minutes after she arrived, she began to have increased drain output, became hemodynamically unstable. At this point, pressors were restarted, the cell saver was reinitiated, and the husband was at the bedside the entire time, pleading with the providers to transfuse his wife. The hospital legal team was again consulted, and they confirmed the inability to transfuse, and this patient progressed to have a VFib arrest. She was coded for about 25 minutes, but unfortunately the code was called. There was a later debriefing among department members, And some providers said they would have refused to do this case given the high likelihood of death and the inability to transfuse. And one person said that he would have actually transfused against his patient's wish. So who are Jehovah's Witnesses? Well, they span over 110 congregations spread across nearly 240 countries. There's, as of 2010, about 8 million publishers. What's a publisher? Well, that really refers to a Jehovah's Witness who actively is spreading the word of the church. There's many other people who attend services, including many minors. As you can see from this chart, the blue line represents the number of publishers, and this has been steadily increasing for the past 30 years. But what's more dramatic is that green line, or those folks that attend memorial services. So it's over 18 million people as of 2010. Within the United States, Jehovah's Witnesses are spread throughout the country, but you can see clusters around these major metropolitan centers. So here comes the question. Did I just present a really extreme case that's isolated, or does this large population actually have an increased risk for morbidity and mortality? Well, it turns out that they do, and there's been a number of population-based studies that have addressed this issue over the past 10 to 15 years. The first of these was done in 2001 in New York, where they looked at almost 400 deliveries and saw that there was about a 44-fold increase for maternal mortality when it came to hemorrhage when looking at Jehovah's Witnesses versus the non-Jehovah's Witness population. The Netherlands performed 2 reviews of their national databases in 2009 and saw that compared to the general Dutch population, Jehovah's Witnesses actually had a 130-fold increase in maternal mortality when suffering a significant hemorrhage. Finally, in 2014, a group in New Jersey that practices at a bloodless medicine center looked at all of the patients who refused transfusion between 2003 and 2012 and found that overall the study mortality was a little over 8%. However, once the postoperative hemoglobin fell below 8, for each additional fall of 1 gram per deciliter, the odds ratio of her death increased quite dramatically, almost by 2. And they saw that once you get below around 5 to 6 postoperatively, there's a rather dramatic increase in the risk for mortality. So I hope I've shown you that this is a large population that does have an increased risk. But I want to tell you a little bit about who these folks are. So in the late 1800s, a Bible study formed in Pennsylvania, and the focus of this was a literal interpretation of the Bible. As this group grew, ABO blood groups were discovered, and the first transfusion of stored blood was given. And in the 1930s, this group took on the name Jehovah's Witness. The ban on accepting blood transfusion did not exactly exist until the mid-1940s. And it was not until the early 1950s that the Watchtower, or the governing body of the Jehovah's Witnesses, revealed why they prohibited accepting blood transfusion, where they equated receiving blood to actually eating blood. And there are a number of passages within the Jehovah's Witness Bible, or the New World Translation of the Holy Scriptures, that address this belief. Jehovah's Witnesses believe that the consumption of blood or accepting blood goes far beyond any sort of dietary issue, and there's actually a moral issue involved. They believe that blood has significance as life provided by the Creator, and this should not be misused. And further, they believe that accepting blood is actually a sin against God, and that they would be punished gravely if they do accept that. Refusal of blood is not just based on this biblical interpretation. Many Jehovah's Witnesses believe very strongly in the option for successful bloodless surgery, including very complex procedures such as cardiovascular, organ transplantations, and large orthopedic surgeries. Many Jehovah's Witnesses also have a strong fear of the adverse effects of transfusion. Unfortunately, one of the studies quoted in some of their literature is from 1960s and gives a rather skewed view that the risk of death is around 1 in 1,000 to 3,000 transfusions. Finally, there's a significant and real fear of being ostracized for their community if they do accept a blood transfusion. In 1961, accepting blood was considered to be a disfellowshipping offense. And this is exactly as it sounds. Jehovah's Witnesses were actually eliminated from being part of that community and shunned by their friends and family. This was happening to about 40,000 people per year as of a 1994 report. Thankfully, in the year 2000, this was changed to a dissociating offense. And while reinstatement to the church is possible after dissociation, it typically requires months to even years of repentance and humility. So as I'll show you, not everything is prohibited by the Watchtower and refused by Jehovah's Witnesses. But the things that are pretty widely refused include whole blood and the 4 things that Jehovah's Witnesses feel blood would separate into naturally, including packed red blood cells, plasma, platelets, and white blood cells. Apart from that, it really comes down to what individuals are willing to believe and how they interpret those teachings. And so there becomes this area of personal decision making. This involves blood fractions like cryoprecipitate, albumin, clotting factor concentrates, and therapies involving the use of a patient's blood, including cell saver and cardiopulmonary bypass. While cell saver is certainly something that is now advocated to be used in certain circumstances on labor and delivery, it's not something that's necessarily widely available. There's a study of United Kingdom obstetric units in which only about 20% of the responding units would have cell saver available on a 24/7 basis. May not be helpful in those emergency situations in the middle of the night. Things that are widely acceptable to most Jehovah's Witnesses include hematopoietic agents such as IV iron or folic acid, volume expanders like crystalloids and non-protein-based colloids, as well as various surgical techniques like electrocautery or argon beam coagulator. Unfortunately, don't have the time to go into a lot of these different therapies, but I want to talk about a couple of the less unusual ones that may be helpful in these type of patients populations. First of which is erythropoietin. This is an aminoglycoprotein that stimulates red blood cell production from the bone marrow. The use for erythropoietin in both the Jehovah's Witness and acute blood loss population is based mainly on case reports and case series at this point. But in 2008, there was a review in pharmacotherapy of 14 cases of Jehovah's Witnesses who received erythropoietin following a significant blood loss. They found that overall the average hemoglobin nadir was around 3 grams per deciliter, and the erythropoietin dose chosen by the providers varied rather widely. Regardless of that dose, the authors of the study stressed that erythropoietin should be given with IV iron, as these critically ill patients often lack the inherent iron stores to mount the need for this enhanced erythropoiesis that they will see. While it takes typically weeks for a good recovery of hemoglobin, some initial response can be seen within 1 to 2 days. Erythropoietin is associated with mainly minor adverse effects such as hypertension or headaches, but there have been rare reports of more serious things like thromboembolic or cardiovascular complications. Given some of these case reports, erythropoietin has started to be incorporated into protocols to address the care for patients who refuse blood. This is an excerpt from a protocol from a United Kingdom hospital in which erythropoietin is recommended for use during and after acute hemorrhage in patients who refuse transfusion in the obstetric setting specifically. Hyperbaric oxygen, or a pulse therapy of greater than 1 atmosphere of oxygen, is also something that can be utilized in the case of acute blood loss anemia. Mechanism of action is not fully described, but it may be due to improved tissue perfusion and decreased inflammatory cytokine cascade. And it's indicated when the hemoglobin falls below 6, there's evidence of end organ dysfunction, there's an accumulative oxygen debt, and an inability to transfuse. Use of this therapy is somewhat limited based on proximity, and this type of proximity can vary widely depending on the state or region. For example, in Colorado, we have 9 centers that could offer hyperbaric oxygen, and in Florida, there are over 80. When it comes to cost, this is actually approved by the Centers for Medicare and Medicaid for the indication of acute blood loss anemia. We're not typically involved in surgical hemostasis, but when we have conversations with patients, which I'll talk about in a moment, there are a couple things we need to consider. Several hemostatic agents are free of any sort of human blood product, such as Surgicel or gel foam, and should be widely acceptable. However, Tisiel does contain human fibrinogen and thrombin, and the packet insert actually suggests having a conversation with patients who would otherwise refuse blood transfusion. It also contains albumin, so unless albumin is specifically accepted by the patient, this type of product should probably not be used. So I think all of us have probably treated this type of patient and have noted that there is a number of different legal and ethical considerations to take. A group that can sometimes help navigate some of these discussions or provide support are the hospital liaison committee members. These groups were established in the late 1970s and are really available worldwide. and have the role of helping not just the patients, but also physicians caring for Jehovah's Witnesses. They can serve as support people, help provide literature to both patients and physicians, and help patients identify bloodless surgery centers. Getting in contact with these people requires usually a call to the Jehovah's Witness headquarters, or discussing with your hospital whether or not they have that sort of information. But one thing that they can provide are worksheets such as this. These are also available on the Watchtower website and within the ASA syllabus on ethics on the ASA website. And these go through detailed descriptions of many things that may be either acceptable personal decision for Jehovah's Witnesses to help let patients make informed decisions about what they will receive. This type of worksheet is also where we can provide information regarding the medical use of patients' blood for things like cell saver, and for our case, for epidural blood patches. When it comes to actually getting consent, there are another set of considerations that need to be brought into play. The first of which is the principle of autonomy. This really states that in order for a patient to give informed consent, they must also have the ability to have an informed right of refusal. Having a private conversation with patients is really important, and this whole discussion needs to be very free of coercion. Patients may have very different personal feelings than what they're willing to express in front of their friends, family, hospital liaison representative, or other Jehovah's Witnesses. This is demonstrated again by a survey published in the obstetrics and gynecology literature, in which Jehovah's Witness patients asked in private, over 10% of those patients indicated that they would actually prefer to receive a blood transfusion in the case of a true emergency. The principle of substituted judgment refers to who is going to be making decisions for a patient if they are either under anesthesia or otherwise unable to speak for themselves. Patients need to designate a surrogate decision maker, and this principle states that that decision maker cannot vary from the wishes of the patient unless new information comes to light that would call the original choices into question. Many Jehovah's Witnesses carry medical directive cards similar to this that can help with some of these decisions and with some of these making these wishes known if the patient can't speak for him or herself. And these have been upheld as legal documents by the Supreme Court in Canada. Unfortunately, in many cases, the language is quite vague and simply may say that no allogenic blood transfusion be given. Ideally, we would all have time to do a consent that would look something like this, where each individual blood component, blood fraction, and therapy is detailed out line by line, and patients have the opportunity to either indicate acceptance or refusal. So I mentioned that one member of the department said he would have wanted to forcefully transfuse this patient and would not have abided by her wishes. And up until about the 1960s, that would have been something that the legal courts would have supported. However, over the past 40 years, the pendulum has really swung in the other direction. And courts now support the patient's right to refuse blood transfusion, even in the case of imminent death. And if such a forced transfusion does occur, it probably falls under the doctrine of battery or completely unconsented touching. Realistically, if a forced transfusion significantly prolongs, saves, or otherwise enhances someone's life, any kind of damages are going to be limited to something called dignitary tort damages. This is typically a very small amount of money, even as low as $1. So despite battery not being covered by most medical malpractice insurers, many patients would have trouble finding an attorney that would be willing to take this case to court, given the very low likelihood of a significant return. That being said, there is precedent for large decisions made against physicians who performed a forceful transfusion. There was one case in the 1990s that was settled for over $500,000, and another about 10 or so that were settled for a cumulative amount of about $500,000. Within the OB world, there was also a case of a forced transfusion in which custody of an unborn fetus was given to physicians caring for a mother who was suffering an acute hemorrhage and refusing blood transfusion. That patient was forcefully sedated and transfused against her will, and a healthy baby was born a few days later. Several months later, that court decision was overturned by the Supreme Court of Illinois, stating that they could not force a woman to undergo an invasive procedure on the basis of saving an unborn baby. The ASA Committee on Ethics also weighs in for this topic, and they maintain a guideline that was updated in 2013. And this gives some leeway to anesthesiologists and says that if you really do have an irreconcilable ethical or moral dilemma in taking care of one of these patients, you can give up the care of those patients, provided that you can find an appropriate and willing anesthesiologist to take over the care. Ultimately, what we can do for these patients really depends on what we are allowed to do. In the best case scenario, we meet these patients well before they present to labor and delivery and engage in frequent antepartum consultations, again, focusing on having these private conversations in which you can go into depth about why they're refusing and what exactly will be accepted or refused. Documenting this in a very detailed way can also be very important, not only for you taking care of the patient, but so that the entire healthcare team knows what the options are, and also to help with those situations where the patient is unable to speak for herself. I think it's also very important to stress that the risks for maternal morbidity and mortality really are increased for this patient population. And I think we can't be afraid to use the word death when we're talking to these folks, given the risk of hemorrhage in the obstetric setting. We can try to optimize starting hemoglobins, again, with things like IV iron or erythropoietin. And we can try to anticipate and identify and hopefully avoid some of the risks related to more significant postpartum hemorrhage. However, we all know that unexpected hemorrhage does occur despite our best intentions and preparation. And in those cases, we do our best with what we are able to give. And in really severe hemorrhage, we can consider some of these less usual treatment options, especially in a life or death situation. That's it. Thanks for listening.